Good discussion. So a couple more subjects we wanted to bring up before we close. And maybe don't want to spend a lot of time on this one, but just want to mention it because it was brought up earlier, and that's personalized medicine and this concept of biomarkers. Now, the challenge is we can't just say, you know, poof, we want a biomarker and make it so. Fortunately, I think a lot of the pharmaceutical companies are in development or working down this path, which is good because they're the ones that are going to have to do this. My comment in just bringing this up is that, you know, is to people who are working on those kind of things, what we want is something that will give us a yes-no decision. So there are enough things out there that help shape or guide a decision, but all they do is maybe increase costs. They don't really give the providers enough the answer to say, is this going to work or is this not? So that's where we would ultimately like to end up, is have a biomarker or something that would say, yes, this drug is going to work in this patient at this time.
You know, in the prostate cancer world, as David can attest, there are a number of companies looking at this in various phases, whether it's going to be for those patients that we're considering active surveillance, for those patients that have received definitive therapy, but they may need adjuvant radiotherapy, and obviously for the disease-advanced prostate cancer patients. And again, with this myriad of drugs, all with different mechanisms of actions, it's, you know, we need to somehow figure out what's happening at the tumor level and make the appropriate therapeutic decisions. And this whole concept of companion diagnostics and being able to follow and you know, really say, yeah, as you talked about, this drug should work on this. We're not going to treat 1 million patients with immunotherapy. This genetic profile, this proteomic profile, absolutely makes sense. This doesn't. We need to look at the androgen receptor signaling inhibitors, you know, biosynthesis, you know, inhibitors or whatever. So absolutely, I think that's where the whole world in oncology in general is moving.
Yeah, unfortunately, we would all like yes and no, but that doesn't work in medicine most of the time. And then when it does, I'm very skeptical of things. You know, it's not penicillin for pneumonia and so forth. You know, a lot of people throw this term personalized medicine around, and I don't think that a lot of people know exactly what it is and how to define it and what it means. It sounds good. When you go see your doctor, I personalize your treatment. You know, the issue is a lot of times you have to throw a lot of stuff up on the wall and see what sticks and what doesn't. And oncology is probably the worst in that area. When you do clinical trials, the winner takes all, the loser loses, and most of the time there are more losers than there are winners. And it would be nice to have markers to be able to help us direct it. And we get a lot of lip service for markers for melanoma and other sites, but if you really look at the bottom line, how much difference does it make even in breast cancer, the delta is not huge. I think that prostate cancer is 20 years behind in a lot of areas. As Dr. Concepcion said, in the past couple of years, we've had some markers that have come through, which I think are important. I mean, they're markers that help us determine who to biopsy, when to rebiopsy. There's one called Confirm MDX. And probably another one that is extremely important in these ones, all this controversy about overdiagnosis and overtreatment and screening and early detection, whatever you want to call it. The whole thing is we got into this mess because we didn't separate diagnosis from treatment. And everybody was getting treated, and they were getting overtreated. Not everybody, a lot of people were getting overtreated. And now we have some markers that give us some idea, cell cycle progression genes and other housekeeping genes and things that are looked at, a couple tests. The issue is that you guys want to know that if you order the test and spend $4,000, it's going to make a difference in the direction you go. That I ordered this test and it says you got a 3% chance you're going to progress and you're still not going to do a radical prostatectomy. And it's not going to be 100%. And so I think that's what we're seeing, and those studies are ongoing, and folks aren't paying for it until they show that you make a difference. You know, there's the other prognostic test when somebody has something. When, you know, so we did this huge study with radical prostatectomies and positive margins where we gave radiation, and it took 13 years to show a difference, and there was a survival benefit. And now everybody's saying everybody should get radiation. However, there were a lot of people who got it that didn't need it. And now there's some markers that can say, okay, we'll take a radical prostatectomy specimen, we will look at a genome-wide thing that's been done. We identify 35 genes. If it's present, you have even though you got a bad specimen, you don't probably need post-op radiation. You don't need hormones. That's huge. The saving there is huge. We just need to implement that stuff. So, you know, there's stuff out there. We just need to integrate it, and that's another exciting area in prostate cancer. And do we have a HER2 new receptor or something? No, but we have an androgen receptor, and people are going to get smart enough to figure out the mutations of the androgen receptor to say abiraterone not going to work, enzalutamide won't work. You alluded to earlier, David, an intermittent therapy trial that SWOG did, and there were a group of people that if you didn't get your PSA down less than 4, you had a 13-month survival rate, and you know, we need to focus on those. So there's a lot of stuff out there. We just need to, you know, act on the information we have and try to move forward.